Good evening and welcome to this Safe Session program. It's a real joy to see you all once again after a month. SAFE is a safety awareness for excellence. It's a monthly learning series, an initiative from the Association of Nurse Executives India. So patient safety is not merely a responsibility, it is our commitment that every health professional makes to ensure that every patient receives safe, effective, and compassionate care. Through these monthly learning sessions, we strive to build a culture where learning is continuous, errors become an opportunity for improvement, and excellence becomes our everyday practice. On behalf of ANEI, I warmly welcome all the nursing leaders who are here, educators, students, and patient safety fellows who have joined us today. So before we could begin our session, let me share the screen.
लेकिन
Not able to see. Eshita, you'll have to make me a co-host. I'm not able to share my screen.
You are the co-host, ma'am. Just click on that share button.
No, it's not there. That
Do you get it, ma'am?
Yeah, got it. You're able to see my screen?
Yeah, it's going to start. Yes, we can see, ma'am.
Okay, right. So before we begin, we have any anthem. So I request
Ma'am, the sound is not coming. It's not audible.
Okay.
Make sure you click share sound.
Yes.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight. Upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
నాకు కనిపిస్తుంది చేస్తా.
Thank you. So this particular safe session is brought to you by ANEI Patient Safety Fellows. I am proud to acknowledge that this particular session is a monthly program, and these patient safety fellows have undergone a structured training in patient safety and quality improvement and are committed to spreading awareness and building capacity among nursing professionals across the country. Their dedication reflects ANEI's vision of developing nurse leaders who champion safer healthcare system. So the Culture of Safety, July 2026 session. The ANEI Patient Safety Fellows, along with the Patient Safety Movement USA, they do a 2 years of fellowship program. And every month, dedicatedly, we have sessions conducted online, and many of you have joined earlier, would have enriched with the program. And today we will be seeing one of such session. So the annual Patient Safety Conference is scheduled on 18th September, where 2025 fellows will be presenting their patient safety improvement project, which they have done at their area. So I request each one of you to kindly block your dates and be present for the conference. The registrations have started. So we have competitions which are held before the conference. We have 4 competitions: the poster competition, nurse-led research competition, quality improvement project competition, and nurse-led clinic show. So these competitions will be conducted online, and those who have our prize winners will be coming up to the conference day. The first prize winners will be presenting and they will be awarded. We have 3 prize winners for each of the competition. So kindly make a note: September 18th, Safer Care for Life, Patient Safety in Non-Communicable Disease. This is the theme for this year's Patient Safety Day. So 18th September at KIMS, Secunderabad. So as I have already told you, ANEI Patient Safety Fellowship is a 2-year program, and the batch of 2025-27, we have made a calendar of upcoming new projects and topics which is of great interest. And this July month, medication safety in emergency and critical care is presented by Sagarika. And we also have already the 6 months of programs which have already been completed. And every year the fellows do programs, and these are all in our YouTube. So you can watch, and even during your clinical training programs or as nurse educators and as academicians, you can show it to your students. It will be of great help to enrich their knowledge. So today, as I said, Sagarika, who is the fellow of 25-27, will be presenting. She is mentored by Eshita Chanda, who was 2021-23 batch, the first batch of ANEI Patient Safety Fellow. And next month, we have Medication-Related Falls and Hidden Patterns by Jyoti Mary, who is also a fellow of 23-25. So all the topics are presented by the ANEI Patient Safety Fellows. And I also want to bring it to your notice that very shortly we will be releasing our template for the next batch, 26-28 batch of ANEI Patient Safety Fellow. So this is purely an online program where at your workplace you can study and do your projects at your own hospital and present it. So once a year we meet at this patient safety conference and present our project, after which the second year you will be mentoring your junior cohort, and together we will be doing a lot of programs and projects. So please wait for your chance to join in. Next month we will be sharing our template. So thank you, and we will be going on to Sagarika, who will be presenting today. So Sagarika is working as a senior manager in Nursing AIG Hospital, Hyderabad, and she holds an MSc Nursing degree. And she works with the critical care nursing and has over 15 years of experience in clinical nursing, nursing leadership, patient safety, and quality improvement. She's a very passionate person who's enhancing patient care through evidence-based practice and staff education and continuous quality improvement. So over to Eshita and Sagarika to take up the session. So please encourage your other friends to kindly join in. And you can post your questions in the chat box. At the end, we will be clarifying all your doubts. Thank you. Over to Eshita.
Thank you, ma'am. And good evening, all of you. So today we have an interesting topic as we are doing the series, as Rosalind ma'am has already mentioned. Now, a question to all the participants here. We all know medication safety is the most priority task as a nurse. But why we are focusing on critical care and emergency? Can anyone quickly unmute yourself and give me the answer? Our topic is only related to emergency department and ICU.
Because emergency department follows many high alert medications.
I think Ishita is having a connectivity issue.
Sagarika?
We have a time pressure. And when we have a time pressure, we know that we, as a human being, we have an urge to make an error. So because we know the chances of error is high in that area because of the patient flow, as well as the criticality of the patient, as well as the complex procedures that the nurses are assisting the wrong patient or the wrong dose.
Eshita?
I think Sagarika, you should start.
Okay, ma'am.
You can start sharing because Ishita seems to be having an internet
Connection as well.
Thank you, ma'am, for your kind introduction. Good evening, everyone. Thanks for joining today's section. My sincere gratitude to Ma'am Tankam ma'am for giving me the opportunity to be a part of the ANEI Patient Safety Fellowship. I would also like to express my heartfelt thanks to Ma'am Rosalind for her constant guidance and support through this journey. A special note of appreciation to my mentor, Ma'am Eshita Chanda, for her continuous encouragement, valuable mentorship, and dedicated efforts in helping me preparing this patient safety section. Thank you all for your support. With your permission, I would like to share my screen and take you through today's section.
keep it in the slideshow mode.
Full screen.
Yeah, click on the slideshow mode. Yeah.
The topic of today's presentation is medication safety in emergency and critical care. Medication safety is one of the most important pillar of patient safety in the fast-packed environment. Even a small medication error can have serious consequences. Through this presentation, we will discuss common medication safety challenges and practical strategies to prevent errors and improvement patient outcome. Let's begin by imagining a typical shift for an ED ICU nurse. In a single shift, a nurse may administering emergency medications under tremendous pressure, handling high alert drugs, taking verbal orders, managing multiple critical ill patients, and making rapid decisions under pressure. In such a fast packed environment, how do we ensure that every medication reaches the right patient safety? To understand how medication errors occurs and how they can be prevented, let's follow the journey of Mr. Rajesh. Mr. Rajesh, 68 years old male with diabetic, hypertensive, CKD, atrial fibrillation on warfarin, presenting with septic shock from severe pneumonia and confusion. Vitals, BP 82 by 48 mmHg, heart rate 138 beats per minute, respiration 38 per minute, SpO2 88%, saturation 13, temperature 39.1 degrees Celsius. Diagnosis is severe community acquired pneumonia with septic shock. Random blood glucose 310 mg per dl. He is shifted to the emergency resuscitation area. Then the physician orders is oxygen, noradrenaline infusion, insulin infusion, heparin, withheld warfarin, antibiotics, and blood workup. Before we explore the case further, I would like you all to share in chat box where do you think a medication error is most likely to during this fast moving resuscitation. Before we continue the case, let's look at why medication safety deserves our attention. Medication error statistics. Why this topic is matter? Medication errors continues to be one of the leading patient safety concerns worldwide. Patients in emergency and critical care are especially vulnerable because they require multiple medications, rapid clinical decision, high alert drugs, and frequent changing in treatment. The data in this slide clearly reflecting the magnitude of the problem. Nearly 1/4 of patients in the emergency department experiencing a medication error, and in the ICU, almost 78% of serious errors are medication related. More than half of these errors occur during medication administration, the final step before the medication reaches the patient. The Indian data also highlighted that medication errors remaining a significant challenge in our healthcare setting. However, it is also give us hope. Quality improvement initiatives and standardized safety practices have significantly reduced medication errors. These statistics reminding us that every medication we prepare, administer, and document has a direct impact on patient safety. This is why medication safety is not just a protocol, it is a professional responsibility shared by every member of the healthcare team. Let's relate these statistics to our patient, Mr. Rajesh. As a critically ill patient receiving multiple high alert medications and requiring rapid intervention, he falls into one of the highest risk group of medication errors. His case reminding us that behind every statistic is a real patient whose safety depending on the decision we make every day. Now that we've seen the importance of the topic, let's look what we will achieve by the end of the section.
In India, yes, in all the
Understanding why medication safety matters in emergency critical care and able to identify common medication errors in emergency and critical care. Recognizing high alert medications and the safeguards required while handling them. Understanding the human factors that contributes to medication errors and apply key medication safety principles in daily practice. We will also discuss how effective communication using the SBAR framework, timely incident reporting, and a just culture can strengthening medication safety. Finally, we will explore the important role of patients and their families as a partners in safe medication practices. With these objectives in mind, let's begin by understanding the types of medication errors commonly encouraged in emergency and critical care setting, why medication safety matters in emergency critical care. Why medication safety matters? Because high patient acuity, high alert drugs usage, rapid decision making, complex drug therapy. Let's return to Mr. Rajesh case and see why medication safety becomes even more critical. Mr. Rajesh, he needs five high alert medications within minutes: noradrenaline, insulin, heparin, broad spectrum antibiotics, and IV fluids, all on the ISMP high alert medication list. Speed and risk are inversely related here. The faster the team must work, the greater the chances of medication errors. Safe medication practices save lives. High risk environments. First, let's understand why emergency and ICU settings are considering high risk environment. Emergency and ICU settings are inherently high risk for medication errors because of time pressure, multiple simultaneously interventions, verbal orders, and unstable patients. Here I would like to say that nurses are the final safety barriers before medication reaches the patient. Here, what human factors do you all think increasing the risk of medication errors in this situation? Human factors. Apart from the environments, let's explore the human factors that contribute to medication errors. Fatigue, alarm fatigue, cognitive overload, similar drug name packaging, time pressure, and communication gaps. Medications errors are often system failures rather than individual failures. Here, what human factors increasing risk in Mr. Rajesh case? Heavy workload, interruptions, environment distractions. As we all know, common medication errors. Let's see common medication errors versus potential consequences. We all familiar with common medication errors such as administrating the wrong medication, wrong dose, wrong patient, wrong route, or wrong time. However, this slide highlights an important message. Medications errors rarely stop at the point where they occur. If an error is not identified and intercepted early, it can progress to an adverse drug event, lead to prolonged hospitalization, increased healthcare cost, and most importantly, resulting in patient harm. Back to Mr. Rajesh case scenario. Followed this exact pathway, a wrong drug selection on involving heparin and a wrong dose error involving insulin were identified before causing permanent harm. This reminds us that timely detection and strong safety barriers can prevent errors from reaching the patient. This bridges into the two detailed case studies that we will see next slides. Let's apply this concept to our first case scenario. While preparing the heparin 5000 units ml infusion, the nurse nearly selected 25,000 units while instead. Due to look-alike, sound-alike packing, a recognized ISMP high alert list. Was this an incident or near miss? And what is the learning here? This is a classic near miss because the error was detected before reaching to the patient. Fortunately, an independent double check identified the error before administration results in no harm to patient. These all separate storage, color label, tall man lettering, independent double check, and prevent most of the errors before reaching the patient. Now let's look another case scenario where the actual error reached the patient. Later, during insulin pump is programmed at 10 units per hour instead of 1 unit per hour. A 10-fold rate error and the dose error reduction system alert is overridden. Unlikely, the heparin is near miss. This error reached the patient and his blood glucose dropped from 310 to 32 mg/dl. Let's identify which safety barriers failed which could have prevented this incident. No independent double check of the pump rate. The dose overridden alert went unverified. Leads to severe hypoglycemia. How can we prevent such errors? After seeing how errors can occur, now let's look at how we can build these safety barriers. Preventing strategy. Preventing medication errors required system-based approach rather than receiving an individual vigilance alone. The strategy shown here including SBAR communication, medication reconciliation, technology safeguard, safe medication administration, safe storage, patient and family engagement, and timely instant reporting work together to create multiple layers of protection. Had these safety measures been constantly applied, Mr. Rajesh, medication errors could have been prevented or detected even earlier. The goal is to build a system where one missed step does not result in patient harm. The first strategy is effective communication using SBAR. How SBAR improves medications? Reduce communication errors, prevent verbal order misunderstanding, ensure complete information transfer, support medication administration, improve handovers between the teams, enhancing patient outcome. As we all know, SBAR situation, background, assessment, recommendation. Let's return to Mr. Rajesh case. During handover, the outgoing nurse communicates using SBAR the patient's septic shock, CKD, current infusions, and the recent hypoglycemic events are clearly communicated. Because of structured communication, the receiving team immediately understand the patient condition and continues safe care without missing critical information. This demonstrates how SBAR reduce communication errors and prevent medication related harm, both of which were risk points in Mr. Rajesh case. Transitional care. Another important safeguard is medication reconciliation during every transition of care, whether at admission, transfer ICU stay, or discharge. Mr. Rajesh daughter mentioned he already takes warfarin at home to illustrate the risk of on dangerous interaction with the ICU heparin. Now imagine if nobody asked about Mr. Rajesh home medication and without medication reconciliation, he could have received both warfarin and heparin, significantly increasing his bleeding risk. This simple process prevents duplicate coagulation and dosing errors, ensuring continuity and safety throughout the patient journey. The goal, medication reconciliation, exists to prevent omissions, duplications, and interactions across the transition care. Technology, a safe partner. Technology also plays a significant role in improving medication safety. Systems such as barcode medication administration, smart pump infusions, electronic medication administration records, clinical decision support system, and automated dispensing cabinets helps reduce medication errors in different stages of the medication use process. Return to Mr. Rajesh case. Barcode scan could have identified the wrong heparin vial before administration, while smart pump dose limited could have detected the tenfold insulin infusion error. If this alert had been acted upon rather than overridden, the episodes of severe hypoglycemia could have been prevented. Technology supports but does not replace vigilance. Safe administration practices. Even with technology, safe medication administration practices remaining essential. In Mr. Rajesh case, several safety checks could have interrupted the error chain. An independent double check may have identified the wrong heparin vial before administration. Careful verification of infusion pump setting could have prevented the tenfold insulin overdose. Simple practices such as using two patient identifiers, following the 7 rights, verifying allergies, minimize interruptions, labeling syringes immediately, using closed loop communication and documentation accurately are small actions that make significant difference in patient safety. A pinch mnemonic. Let's now focus on high alert medication using this a pinch mnemonic. A simple way to remember medications that requires extra vigilance in emergency and critical care. A pinch standards, anti-infectives, potassium electrolytes, insulin, narcotic sedatives, chemotherapeutic agents, heparin, anticoagulants. Connecting it back to Mr. Rajesh case scenario, he touched to a pinch category directly, anticoagulant and insulin. The wrong heparin vial was selected. The tenfold insulin dose error occurred. These medications are considering high alert because even small error can cause severe patient harm. Whenever we administer a pinch medication, we must be extra vigilant. Why these categories demand extra vigilance? Because as we discussed in the previous slide, errors involving these medications can rapidly progress to severe patient harm if safety barriers fail. Safe storage and organization. Medication safety begins long before the medication reaches the patient. It started with safe storage and proper organization. Why was the wrong heparin vial selected? Let's revisit Mr. Rajesh case. One of the contributing factor was the selecting of the wrong heparin vial. This may occur because of lookalike packing, similar labeling, or improper storage practices. By storing different strengths separately, using tallman lettering, applying high alert labels, maintaining clear labeling, following FIFO principles, and performing regular expiry checks can be significantly reduce the risk of selecting the wrong medication. Simple system changes such as this plays a vital role in preventing medication errors and improving patient safety. Patient and family engagement. Medication safety is not solely the responsibility of healthcare professionals. Patient and their families are valuable partners in preventing medication errors. Our patient daughters become an important safety partner where she tells staff he is allergic to ceftriaxone. This prompts the team to review the prescription and change the medication before it was administered, preventing a potential serious adverse event. This example reminds us the informed and engaged patient and families add an important layer of safety to medication engagement. Instant reporting, just culture. Despite our best efforts, errors and near misses can still occur. What matters most is how we respond to a just culture. Encourage healthcare professionals to report incidents without fear of blame. The focus is not on who made the mistake, but rather why did the system allow to happen. In Mr. Rajesh case, instead of blaming an individual, we should ask, why was the smart pump alert overridden? Was the workload is excessive? Was the independent double check is missed? By understanding these system factors, we can meaningful we can implement meaningful improvements, prevent recurrence, and create a safer environment for both patients and healthcare professionals. WHO key recommendations. Let's see how these safety strategies are fully aligned with the World Health Organization medications without harm global patient safety challenge. If we compare Mr. Rajesh case with the WHO recommendations, we can see that every safeguard is relevant. Safe use of high alert medications, medication reconciliation, effective communication, patient engagement, independent double check, and learning from incident. Together, these evidence-based recommendations help reduce medication-related harm and strengthen a culture of patient safety. Safe meds. To help us remember this key principle, I would like to introduce the safe meds, which brings together all the key principles of medication safety. Look into entire case in safe medics. We should have scanned the heparin, assess the allergies and medications, follow the 7 rights, engage the patient daughter, monitor blood glucose, eliminated distractions, double checked high alert medication, and spoken up by reporting both the near miss and the incident. The single mnemonic captured all the lessons from Mr. Rajesh journey. Safe medics remind us that medication safety is not one single action. It is a series of consistent evidence-based practices working together to protect our patients. Every check we perform, every question we ask, and every concerns we raise has the potential to prevent. So what is final outcome? Let's conclude Mr. Rajesh journey and see how the safety practices change the outcome of the case point by point. The heparin vial mix-up was caught as a near miss via independent double check. The insulin pump rate error was recognized and glucose recovered from 32 to 108 mg/dl after correction. Duplicate anticoagulation was avoided through reconciliation, and the missed ceftriaxone allergy was caught at handover via S-bar. Conclude the patient stabilized and patient safely transferred to the ICU. Take home message. Before we finish, let's summarize the key message from today's section. Medication safety is everyone's responsibility, every check, every time, every patient. Medication emergency and ICU settings carry higher medication risk, high alert drugs, time pressure, and critically ill patients increase the risk. High alert medications require extra precautions. Nurses are the last line defense. Patient and families are valuable safety partners. Encourage them to ask, check, and speak up. Technology enhance medication safety. Report incident and near miss. Every message on this slide held true in Mr. Rajesh case, from the heparin near miss to his daughter catching a missed allergy. These are the references that informed this presentation, WHO and ISMP guidelines and real-world case reporting. Medication safety is not about working faster. It is about working safer. Every check, every question, and every double check can save a life. Thank you.
Thank you, Sagarika. You may just remove your slides. We can just stop sharing your slides.
Yes, ma'am.
Yeah, stop sharing. Yeah, thank you. So, can we have some questions from the participants? No questions? That means all of you have understood or nothing went inside. Knowledge boosting, nice presentation. Thank you. Any doubt?
Hello, excuse me. I want to ask one question to her. Very nice presentation, which I may say, and very this presentation actually eye opener for us also. I want to ask that if a nurse is doing exactly mistake, then w- how we can assess the knowledge, because which I have also found that nurses are doing the mistake for heparin dose. Exactly, they are not knowing that the not having the knowledge about the 5,000 and 25,000. So how we can cope up with this situation in a large number of nurses? How can we go for the educated that our nursing force to purposefully prevent such kind of incident?
Can I answer to that question? It's a wonderful question, and some new idea is coming to my head. Can I answer that?
Sure, ma'am. Sure. Good evening,
Yes,
Sucharita is
ma'am.
here.
I thought it is Sucharita. I thought so. Okay. So I have not tried this before, but since new problems, new challenges, so we should come up with new solutions. So I'm just thinking, suppose you have heparin vials which are completed, 5,000 per ml, 25,000 per ml, your vials are available. Collect them, put regular water into the vials, okay, and create a simulation based learning. Okay. So you can actually create a scenario where the nurse is by mistake in a hurry taking. First of all, when heparin is being loaded, there should be a second person checking. That is the protocol. So, this discussion can come when you actually do the simulation. You can create a scenario wherein the two vials are there. You can start with all the wrong things that can go wrong. Number one, 5,000, 25,000 vials should not be sitting nearby. They should be far and they should be in different, drawers. So, okay, mistakes can happen, they can be together. So, you can show the nurse drawing up and make sure that your video shooting shows that she has picked up the wrong vial. And then you can lead a small discussion to ask that what can go wrong with the patient. Instead of 5,000, you gave 25,000. Now, what can go wrong? It's not real patient. You can just have an actor, one nurse itself can be an actor. So ideally create one learning from error kind of a scenario, a short video which can be seen by all your nurses, and you can share that with all your nurses. You can call them to the classrooms, ask them to see the video, and then lead discussion. See, current generation is not for a lot of theory. They know the actions of heparin. They know how heparin is available, what can happen, all these things, but they have to see that something is going wrong. That is one idea. The other idea is that when you actually have an error, let's say there is an error, you caught it, but nothing happened to the patient. But you can create a storyboard in which the patient actually can bleed and end up in the drastic situation. So if you show that story to them and ask them to reflect, could a nurse could have prevented that patient from losing his life? So these are scenarios you create. I think, Sucharita, you create once and have that video ready and run it through, and also actually have those vials and let them look at the vials and say this is the doctor's order. So keep the vials together, see that whether they are able to read the label correctly, because whatever policies you make, healthcare can have risk. You have protocol which says Tolman and a different shelf, everything you have done. Nobody is going to audit this every second, right? One nurse can pick up from one shelf, she'll put it in another shelf. So only way that we can prevent the error is the bedside nurse when she is loading. That's the time and yes, telling them whatever busy it is, get somebody else to double check with you. Heparin at least have got an antidote, but there are many drugs where there is no antidote. You will not be able to take it back. So such discussion is important. Discuss the whys about it. Uh, have I answered your question, Sucharita?
Yes,
Anybody else
ma'am.
wants to add if you have done something different? This is, just an idea came to me when you were asking just for the heparin thing. I have also gone through that thing, a couple of times. Yeah.
Now, one thing which I used to practice in my previous organization is something a game called a scavenger hunt. So we used to give them stickers, okay, of color like heparin 5,000, heparin 25,000. So in within few seconds, they have to go and locate and put the sticker in the cupboard where there is. Because most of the time we found that this was a problem, that in the crash cart also they fumble where and they keep on pulling the drawers. So we started doing this game called as scavenger hunt where they will have the chits written in that where are the drugs, so they'll go and stick it on, and then when they open it they see whether exactly they have put it correctly on. It's just like a fun way of game.
Yeah, yeah. I mean, this game can also be called as find it yourself.
Yeah, you can do that.
Scavenger, find it yourself. So in Fortis, we started the orientation when new nurses come. We did not show them where what it is. So we gave them a list and said, go and find it yourself. Whatever you can't find, you come back and ask. So they will know where is cannula 20, where is cannula 24, where is this medicine, the most common things. Otherwise, it's pretty much not possible for anyone. So the scavenger hunt is a good idea. I mean, let them locate things themselves. And there are many different ways you can do this, and heparin is a very commonly used high alert medication. And in emergency and in
Critical care areas.
critical care, where the timing is so less, you are supposed to act very fast. So there, having the next standing staff to have a look. You should kind of practice that and say, hey, just look. You don't have time because the patient needs that medicine quickly, right? You should have that habit. There's a double check that's happening, independent double check that's happening. It is not worth harming a patient. It is worth always taking that half a second to double check, right?
Yes.
Yes, sure, ma'am, sure. It's very important for us to know exactly right things and to teach our juniors the right things.
Yes, yes, yes. Very good presentation, Sagarika. And if anybody else has got anything to share, and okay, there's someone wrote here. There is 13 rights now, ma'am, but following 10 rights. So let me tell you, this is my very personal take. It has nothing to do with anybody else. I feel if we as nurses, if we can follow 6 rights all the time, forget about the 10 and the 13. We are still struggling with the basic rights. Anybody will come and tell me, we are very good with the 6 rights? Can anyone tell this confidently to me? I think we are running and trying to do so many things without making sure the basics are there. I would say fix your 6 rights first. So tomorrow there will be 15 rights, there will be 20 rights, and we are still struggling with those. The first right, the right patient, because we don't identify the patient. Then where are we going? So this is my personal take. Please, please go back and see that. Have you succeeded in implementing 6 rights every time? Whether it is 5 or whether it is 6, it doesn't matter. I just want to make sure documentation is included in that, right? Because that is mandatory for us, right? Yes, I would always invite a discussion around this, even a debate. I don't have any problem. What do you think? Somebody should,
Many of the time,
respond.
ma'am, these things happen. This is Shilpa, madam.
Yeah.
Incompatible drugs, no, we mix certain syringes and IV lines. When we in 3 lumen, वगैरह, when we insert and certain drugs are mix and then the reactions take place. That is also one of the experience that I have in my clinical postings when I was in ICU.
Okay. So there I have one tip. I'm a critical care nurse. I mean, the recent practitioners can also chip in. There are two types of drug-drug interaction that can happen. One is when you are admixturing, when you put medicine into ringer actor, saline, or only dextrose. That should be known to the nurses that this drug can, or I can very clearly remember amiodarone. Calderone can only be diluted in dextrose. It cannot be diluted in anything.
Always get that,
So
madam.
you can have those chart. The other thing that when I was a critical care nurse. I had this problem. I was in charge also. So we used to say either it is SMS or SAS. That means saline, administer medicine, saline. Saline, medicine, saline. SMS or SAS every time. You don't need to worry what medicine are you giving. So you have to give saline flush in between, except in those cases where even a couple of ml of fluid can make them fluid overload. So that those patients are not too many. So that is something for the leaders to keep a watch and have this safety discussion at the beginning of the shift, that can this patient afford to have SMS, how many medicines are going as an IV push. So that discussion should happen. So Shilpa, thank you for bringing up that point, because what it means is all of us need to be very aware where we are working, what our, if you are the leader, if you are the team leader, if you are an in charge, be aware what your nurses are going to administer. Have a awareness of what is happening around. I mean, we should not be blindly giving medications, right? And ask them what is their challenges. So if you say SMS, if they say that we don't get saline, we have to fill so many ampules, so understand what is the operational issue. You have to just give an answer. For us, or everybody, every nurse should know what is the dead space volume. So some people think in between the medicine, I have to give 5 ml, 10 ml medicine, 10 ml saline. You don't have to give, because the dead space is so small. So 110 ml of saline, if you are using, you can very easily give multiple drugs. Give the medicine, flush the tube, flush the line, again give the next medicine, flush the line. So I hope that I have given that answer. I loved this medication safety series, because that's why I make time to be here, because I think this is one safety that we just simply cannot overlook. All the safety aspects are extremely important, but I think in this domain, we kind of take shortcuts, don't we?
Yes, we are.
Don't we take shortcuts?
Yes.
True, ma'am,
Yes.
true.
So
Sometimes we
there
are taking
has
the
to
chance.
be discussion with the youngsters that what prompts them to do shortcuts, and when they take shortcuts, what can actually harm to the patient. Those narratives needs to be discussed and understood. We should not go and tell the youngsters that the protocol, you are supposed to be double checking. Why didn't you double check? Write an incident report, give me explanation. Finish. They are not understanding. They're only seeing a senior who is sitting on your head and trying to spoil your day. Correct? They'll say, oh, it's very easy for them. Come and look after 5 patients like me. Then you will know what's the pain. So I think it's very important to be empathetically guiding and discussing that why is it important that they should not take shortcuts. We must have those dialogues, because one of the reason when the errors come up, the WHO, it is one of the point, normalization of deviations. For example, if your heparin is a highlight medication and it is very commonly used, and you don't even check whether double check is happening when things are all okay. It's like when you have a problem, you will go after it. You will audit, you will check, you will do this, X, Y, Z. I would say don't become active at the time of war. During peacetime, start checking the processes. Are they safe processes? Are people following it? Then you will come to know that when sometimes you are aware of what has gone wrong, sometimes you don't even know. Maybe nothing happened to the patient. So that double check is very critical because it is difficult to put it into process, because when someone tells me that in our hospital all medications are double checked, I usually tell them, give me a ticket, let me come to your hospital, just spend half an hour. I will prove to you that's only in paper. So don't write policies that that's not possible to be followed also. At least stick to the high alert medication where you really need somebody else to check your medication. I want to hear from more people. We're just 2-3 minutes. We just crossed 8 o'clock, and fantastic discussion and slides. It's equally important to have, some more discussion so that when we go back, we think of doing something different from tomorrow.
Hello, ma'am.
Ma'am, good
Yes.
evening, ma'am.
Good evening, ma'am. Sonal here. Ma'am, actually, I wanted to know, means nowadays, no wise nurses are there in every organization, and we do face challenge of like they are not interested or they are not aware of many like drugs, not only policies and protocols, but then basic things like what is the action of this particular drug. Then they are not aware, and then they land up into the mistakes. So, my question to you is like basically how we can make them more interested in drug study learnings.
Okay. I will give you a real life example. Okay. If you want something ready made, you can go to any website. There is a downloadable PDF with 100 drugs, one drug in one page. So please go there and you can download. That can become like a kunji for your nurses. But I would say how to get them involved. So what we did was that every unit they had to make a drug album. So a drug album means assignment is given to Ishita that she has to write about adrenaline. So what will happen, Ishita, you will create a template and say, Ishita will go and get the label of the adrenaline, which she will paste on that one page. She will write very quickly what is this action, how to give it, dosage, and then nursing responsibility. When you are giving, what is your responsibility? 2-3 points. So you can create your top 10, top 10, 15 based on the speciality. You can create drug album. Then that drug album can be kept in each unit. So I was a critical care nurse in cardiology. So in my ward, I would have a drug album. And most importantly, I had an album of ECG. 100 ECGs were there. And that album used to be borrowed for DNB exam in Saudi. From the medical college, I used to get request, and they told, "Ki, please don't put any answers, just leave the album." And I used to tell my nurses that if you learn 50 of this ECGs, you will become an expert in ECG interpretation. And we had 100 ECG samples. So involve them to create that, engagement. Current generation needs to have little bit of activity and fun. And reading something from the leaflet is pretty tough because they are so small letters, right? Now, all this information very easily available, and you can have a competition between your units that whose drug album is going to come out the best manner. So that means across the hospital there is some halchal happening, right? And that's a competition, and your work is done, you appreciate, you give them some certificates, some trophies to say who made the best drug album. We are not talking about making an album of 100 drugs. No, you keep on learning as you start giving medications, but there are some basic medications that you definitely need to know in a particular unit because they are very commonly used. Then you can slowly start adding more of those. You just need a what you call spiral file and one poster paper like the children they make, no? So you ask them to make with hand. Maybe that will be even better because they put their, and you can ask them to put their name. Created by Ishita, created by Rosaline, created by Tankam. So they will say, oh, even after I leave, it will be there. Right? And instead of putting holes in that, you can use the plastic cover thing, no, with the spiral thing, put them as inserts. And you make sure that nobody steals that away from you. For me, that ECG album was my, I used to just carry it with me because it's so difficult to collect 100 ECG samples. It took me almost an year to collect from my own patients. It was pretty tough. All kinds of arrhythmias, 12 lead ECGs, it was tough. But you can use something like that. Does that sound like a good idea? Anybody has any other idea?
Yeah.
Yes, ma'am. Thank
Yes,
you.
ma'am.
Can I add one more? I love to tease with some games. Okay. So way back when I was also in Fortis, so we did this activity. Like we have chits again. So if I have got Dolo, somebody have got Citrazine, the other party will have actions written on their paper, on them. Okay. So I have to pair up with my action. I hope you got it. One is with the name of the
Yes, yes.
drug. You will run to with your action. So you should know what is the drug that I'm having it. I should know the action. Then only I'll go to the right person. So these are some ways of, fun learning activities of making them learn these things. As ma'am said, I remember my CMC days, we used to have drug presentation. So each one of us have to have a presentation, and that used to be in my ward, where it has to be in the album way, or it is a diary, we used to call it as it. And we were supposed to carry the drug, show them this is a tablet form, this is the injection form, what is the cost of the drug, because nowadays lot of drugs which is very expensive, and even if you do a wrong indent, sometimes the pharmacy doesn't take it back. So it needs to be doing with a lot of other things. So these are some of the ways we can have these quiz, as ma'am was telling. Sometimes match the following also we can do on actions of drugs. Basically, maybe 1 week we had presentations, and then following week you just find it out how much they have retention of those drugs. And one more way of doing it, as managers, as we go for rounds, we can ask the staff, as they have a case presentation in 5 to 10 minutes, just give what is your case presentation of this patient and tell me the drugs that you have administered and tell me the action of it. So if she doesn't know, she knows that, oh, my manager will come. I have to, at least sometimes with fear also, they'll start learning, and that will come slowly. So
I will add to Ishita, carry your, green cards, which says,
yes,
wow, extempo champion, green cards. Okay. So if Ishita lands up and I'm the nurse and I'm able to give the presentation, give all the drugs properly, immediately she will just
that's
say,
right.
hi, Tankam, you are extempo champion. Sign Ishita, give the card. Okay. And they can start collecting cards. And after some time, you can say, whoever, maybe every 3 months, 6 months, whoever gets the maximum green cards, they will get something else. So there is a chain of appreciation that's happening across the unit. The drug is one area. In case presentation, the person is not only knowing the patient, they will know the lab test, they will know the medications, right? So everything is there. So in Fortis, we used to call it as grand rounds. Grand rounds means it's me, my supervisor. I will end up in any ward or not ICU. I didn't know. I'll go to ward because that's where the lot of hesitation was there. Nurses will not speak up. This was more to help them to communicate. They knew it, but they won't talk. So we'll land up and we'll call somebody and say, okay, you talk about your patient. Initially, the in charge was allowed to propose. Ki ma'am, you ask Ishita. So that means she has prepared Ishita. I said, okay, very good, no problem, prepare. After few rounds of grand rounds, I said, now you cannot propose, I will select. So that means if she has 4 5 nurses, she has to make sure all of them are ready. right?
All of them are prepared.
So there is some excitement that happened. Slowly, I used to get call from my in charges saying, "Ki ma'am, grand round nahi hua. It used to be on Thursdays, you know. And if I miss one Thursday, then when I became confident, these nurses have started to talk much better. I will tell the doctor who is there, आप भी आ जाइए. You also stand, listen to the nurse, you know. When she will finish and not a very long time, we gave very limited time, and we had a scoring card also, jo my educator will keep a score, so that everyone knows that we are assessing the grand round fairly. You know, it is not that the one word will say, oh, she was kind here, she was not kind there. So we had a small scoring card also. I'll call the doctors. So when they hear, they'll say, oh, ma'am, very smart nurses. I said, give them a chance. They will show their smartness. So I also get a chance to tell something to the doctors, right? So I think there are a lot of ideas that came, and I really like that idea of having different cards, you know. So I am Rekha. Rekha, firstly, mute yourself. आप किसी को डांट
Rekha.
Rekha, you're scolding someone, okay? So I think that is almost like a puzzle card, right? I don't know if we put our heads together, maybe we can create something. I don't know. Some idea is coming here. Any ideas? I'll try to do something. Let me see. Okay. I think that's great. And
So thank you.
these
Thank you, ma'am. Thank
discussions
you
are
for
very
adding to the
important.
topic.
Dr. Rosaline and Eshita, make sure the discussions are always done. Don't let people go without discussions. There are people who have questions, there are people who can give ideas, but a good question will spark good discussion. So thank you to all the people who participated and also all the people who asked questions. Fantastic session. Thanks to also Dr. Rosaline. Thanks, Ishita. And
Thank you.
thanks,
Thank you,
Sagarika.
Sagarika. Thank you, ma'am.
Thank you,
Thank you,
everyone.
ma'am.
Thank you so much.
Rekha had a doubt. Just a minute, ma'am. Rekha had a doubt about the patient safety conference. Rekha, it is on September 18th. I hope you're an ANEI member.
Yes,
If not,
yes,
catch up with one
he is
ANEI
our fellow.
member.
Rekha is not our fellow. Sorry. I'm sorry. Rekha is a member for sure. Yeah.
So it's for it's on the Patient Safety Day conference on September 18th at Kim's Hospital, Secunderabad. If you have any colleagues who are an ANEI member, catch up, become an ANEI member, or get to know information, or contact me. I'll give you more of details. Patient Safety Fellowship program for the academic year is beginning. So all the patient safety fellows who are here, kindly talk to your colleagues at your work spot so that others can also get benefited. Thank you, ma'am, and thank you, Ishita.
Thank you, ma'am.
Thank you all for joining. Thank you.
Thank you, ma'am. Thank you.